We're so happy you joined today's Lunch and Learn, Healthcare's Impact on Domestic Violence Cases. I am your host, Sherry Curtical, CEO of Victims Voice. Today's program is being sponsored by the Academy of Forensic Nursing. AFN's mission is to link research to practice through the dissemination of scholarships, education, and service to those affected by and responding to trauma. The Academy of Forensic Nursing is dedicated to promoting evidence-based education, scholarships, and leadership for forensic nursing and multidisciplinary. For more information, please visit them on the web at goafn.org or any other social channels shown here. This session is being hosted by Victims Voice, creator of the Victims Voice, the only legally admissible documentation tool that allows victims to safely, securely, and privately store first-hand evidence-based details needed for stronger protections, better investigations, and more appropriate prosecutions. Now proudly serving the needs of our Native American, Alaska Native, Native Hawaiian, and Pacific Islander communities. Victims Voice, giving victims a legal voice. For more information about how your organization can become part of the partner program, visit us on the web or through our social channels as shown here. Today's program is being moderated by Sarah Marie Baumgartner. Sarah Marie has been a nurse for the past 15 years. She has worked in acute care cardiology, outpatient cardiology, and currently works in pediatric home care. She is a survivor of domestic abuse and started MAPS, Project Defense, as a platform to bring empowerment and self-protection training to victims and survivors quickly and discreetly. She is passionate about ensuring the education of healthcare, law enforcement, and security professionals to increase their knowledge and cultivate trauma-informed responses to victims and survivors. Sarah will lead our esteemed panel of professionals to discuss how a more collaborative effort of trauma-informed care covers not just the well-being of the survivor, but all those involved in their care. We'll hear from Diana Fogno, representing the medical perspective, Mike Hodges, covering safety and security, and Chris Jones on risk assessment and law enforcement. Without further ado, I am very pleased and excited to turn it over to Sarah Marie Baumgartner.
Thank you, Sherry, for the wonderful introduction and for hosting today's webinar as well, this Lunch and Learn webinar. And as Sherry mentioned, I myself am a survivor of domestic abuse. I'm also a nurse. I've been a nurse for 15 years. And so this is something that I'm very passionate about. And I think everyone here attending today realizes that we definitely need to have more conversations. And the more that we can collaborate and educate each other in our different aspects and our different roles of law enforcement, healthcare professionals, healthcare security, the bigger difference that we're going to be able to make in victims' lives. So I just want to give an introduction on our speakers today and tell you a little bit more about them. Diana Fogno, she is the founding board director of End the Violence Against Women International. She's also a founding board member and is an immediate past president of the Academy of Forensic Nurses. She is a retired fellow in the American Academy of Forensic Science and a distinguished fellow in the International Association of Forensic Nurses and a distinguished fellow in the Academy of Forensic Nursing. She works for Live Save as a forensic nurse in Marietta, Georgia. In April of 2019, she was a recipient of the National Crime Victims' Rights Week Award given in Washington, D.C. She provides training across the country and internationally for sexual assault and domestic violence, non-fatal strangulation, to assist communities who wish to bring forward teams of healthcare providers. She is also a co-author of numerous textbooks and papers on dealing with the forensic medical aspects of violence, such as The Color Atlas of Sexual Assault, published in 1997, which is the first book of its kind in the nation, and Sexual Assault Victimization Across the Lifespan, and multiple workbooks on the topic. Her latest workbook in 2020, Sexually Transmitted Infection and Non-Fatal Strangulation, are wonderful resources for nurses and physicians when treating sexual assault patients. Next up, we have Mike Hodges. He is the System Director of Public Safety at Piedmont Healthcare in Georgia. He is an engaged and proactive healthcare security leader with over 20 years of military and security experience. His work and interests are focused on proactive violence prevention and strategic employee training. Additionally, Mike has been a pioneer in proactive security solutions, including leading the development of a collaboration workplace violence prevention program that has reduced incidents of workplace violence by over 50% at his facility. Prior to healthcare, Mike was a member of the U.S. Army, where his service included the response to Hurricane Katrina and combat tours in both Iraq and Afghanistan. He is the recipient of the Vizient Brilliance Award for Innovation, the 2018 Montague Boyd Excellence in Publishing Award, the Bronze Star Medal, and the Humanitarian Service Medal, among other awards. Mike has published numerous articles related to violence prevention and officer training. He currently manages the Proactive Security blog and co-hosts the Proactive Security podcast. We also have joining us today Chris Jones. He's a training supervisor for 3M in Clinton, Tennessee. Formerly, he was a training specialist at the University of Tennessee Law Enforcement Innovation Center and National Forensic Academy. Dr. Jones has trained thousands of law enforcement officers domestically and internationally on an array of subject matters. He also serves as a content expert and adjunct faculty at the collegiate level. Dr. Jones has been a featured presenter at multiple conferences, to include the National Association of School Resource Officers and the FBI National Academy Associates in Tennessee and Kentucky chapters. Before joining UT, he was an officer for the Kingsport Police Department. Dr. Jones is the creator and host of the Commander podcast, where he and his guests share expertise on a broad range of law enforcement topics. His academic background includes a Doctor of Education in Leadership and Professional Practice from the Trevecca Nazarene University, an MBA from King University, and a Bachelor of Science from East Tennessee State University. Dr. Jones's passion for helping victims of domestic violence and sexual assault was the inspiration for his dissertation research, quantifying the lethality of domestic violence and implications for enhancing offender prosecution. So those are our panelists for today. And again, we are so thankful that you guys are joining us today, and we will get started with our discussion. All right. Well, thank you guys for being here today and taking time out of your schedule to be here and have this important discussion on collaborating in healthcare and security and how we can help victims when they're experiencing domestic violence. And so my first question is for you, Diana. Could you just briefly explain the role of what forensic nurses do and how they work with victims?
Sure, thanks for asking, and so happy to be here with you all. So a forensic nurse is a relatively new term that's been around probably the last 20 years. So this is a new specialty in nursing, and what it's specifically for the registered nurse or a nurse practitioner, advanced practice nurse. And it's that they deal with victims of violence, offering compassionate care, often intertwined in the medical care, but their main purpose, or one of the purposes, is specifically to collect evidence, identify injury, document the findings, and then testify in court. So simply said, there's four things. So the forensic nurse will do the examination, collect the evidence, document the evidence, and testify in court. So we have to take all of that, and it's often intertwined with other nurses because each specialty has a little bit of forensics in it, if you will. For example, pediatric nursing, those nurses just specifically deal with children, right? So in a nutshell, that's a little bit about it. I hope you do have a few more questions on that.
Yes, absolutely. Yes, so my next question for you is actually, what we're going to do during this discussion is kind of try to follow a victim through the healthcare system as they come in. So when a victim first comes to the healthcare setting, whether that's hospital or the outpatient office, a forensic nurse isn't always on staff and they aren't always there. They sometimes need to be called in. So what do staff need to know how they can initially support that victim before a forensic nurse can see them?
Well, I'd probably say the first thing is whatever the complaint is, start by believing. Now, the patient's either going to tell you the truth or they're going to lie. That's their choice, but we can't help do that deep dive if they're not being truthful. So it's always best to let people know what's going on. And I understand safety concerns. So that's going to be in their ballpark. But the other thing I want that nurse to know is use your trauma informed care principles and say things. And I call these things red flag statements. I'm sorry this has happened to you. We're going to take good care of you. And then try to get them out of the triage area or the waiting area into a room so that um, the final medical provider can do that head to toe assessment and determine what treatment or action items are going to be followed. Oftentimes, they will call the forensic nurse to come in, and so they can just say a special nurse has been called in and she's going to be with you shortly. And it's like, what can I get you? What do you want? So, those are just some things that you might think about saying, and just be kind.
Wonderful. Thank you so much. Chris, so this next question is for you. Victims, oftentimes they can come to the healthcare setting on their own. They don't call law enforcement first. So could you talk about the role of what law enforcement would do when they're responding to a victim that's already in the healthcare setting, and what staff can expect on how they can work with law enforcement?
Well, I'll echo what Diana said, and one of the main things that law enforcement officers need to remember, and everyone in general, is that an informed approach when speaking with victims. If a victim has entered a hospital setting and hasn't law enforcement, then he or she may be very reluctant to cooperate with law enforcement at the time. And that's often the reasons of why they go to see a medical professional first. They don't want to get law enforcement involved. You have to understand that throughout the cycle of investigation, victims can answer the same questions over and over and over. And every time that they're answering the questions they're asked specific to the incident, they're reliving the trauma. So the goal of law enforcement is to have the victim say it once, right? To get the story out, to get all the information out, or all the information that's needed as few times as possible. And once may not be as feasible, but certainly not, I'm going to tell this to a patrol officer. Now I'm going to tell this to an investigator. And now let's escalate it, get another investigator involved and let her retell that story again. And I'll say her because predominantly most of our victims of DV and sexual assault are going to be women, understanding that it could be men, women, whoever. Um, when officers arrive on scene, the very best thing they can do is have a victim advocate meet them there. A victim advocate, for many years now, I have considered myself the advocate's advocate. Because when I was a law enforcement officer, I wasn't aware of all the assistance an advocate would give in relation to this case. In fact, most of the things I heard was they kind of get in the way, which is completely not the case. So if I can get an advocate there that is there not to guide the victim in answering my questions, but in a supporting role, and then give the victim some power and control over when and where that conversation takes place. Because ultimately, if law enforcement is there, he's there to ask questions about the incident that the victim had just experienced. So giving them some of that power and control, and Sarah Marie, you know, most domestic violence or sexual assault is all about power and control that's exhibited by the offender, right? So give it back to the victim and say, hey, would you like to talk here? Would you like to take a little while and come back to the office and talk to me? Where would you feel most comfortable telling me about this incident? Is there anybody that you would like to have here while you're talking to me? Right? Are you warm? Are you cold? Give them some authority, some power and control that they hadn't had probably very recently from the time that they were abused or assaulted or whatever. And then the next thing is, make sure that there's not an audience there while they're telling this story, right? Because if they were in a medical setting, we've got doctors, we've got nurses, we've got security professionals, we've got all kinds of people probably coming in and out of a room. They may not feel very comfortable telling them. And I'll stop right there because one of my instructors, and I love the way that he did this, and it was a little off-putting when he did it the first time, and almost shut the class down completely, but he had a good reason for doing it. He would bring someone up in front of the class and he'd say, okay, now I want you to tell me in a loud, clear, and concise manner of your wildest sexual experience that you've ever had. And you can imagine, especially in a class full of law enforcement officers, they're taken back by his request. And I did have a few that were overly willing to tell their story, but we shut them down. But if you think about it, that's what we're asking victims to do, to tell them about this wild, just crazy experience that they've just undergone and in front of a bunch of people. And that's often how those things transpire. So giving them some power and control over where they give the information, where they relay the information to law enforcement, and preferably an advocate. If you don't have an advocate, you have to make sure that you're asking questions in the appropriate way. And that's probably better for another episode. I could spend an hour talking about the right and wrong ways to ask questions, but my best advice would be to get an advocate or someone that the victim will be comfortable with in the room, especially if you've got a male officer questioning a female victim.
Wonderful. Thank you so much for that. And I can just to kind of piggyback on, having victims tell their story over and over again. One of my experiences in the hospital that was probably really triggered a lot of patients, and just patients in general, was going through and asking them the same questions so I worked on the floor, so they would go through the ER, they would answer all the questions in the ER, and then they would get to my floor and I'd have to go back through and ask them all those questions. And that was probably, I would say, about 80% of patients would be like, why are you asking me these questions again? I just answered them down in the ER. Don't you guys talk to each other? Doesn't anybody in this place know what's going on? So I can kind of piggyback on what you're saying as far as when we're talking to victims, being concise in our questions, not having to ask the same questions over and over again unless we really need to. So that's a great point. Mike, so for you, you are a director of healthcare security. And so could you explain a little bit about what healthcare security does and their role, and at what point would they kind of become involved with the victim or have contact with the victim when they're in the facility?
Sure. So I think there's a couple of intersection points where healthcare security may or may not get involved. Typically it's at the request of our clinical staff and support of a victim that's been identified in our emergency department or in a setting like that. And I think, predominantly the roles and responsibilities that healthcare security take are, helping to ensure the privacy of that victim. So, making sure there's not a bunch of people coming and going from the room. Putting in security protocols like no information patient status, where the potential abuser can't call to the hospital and get information about the patient, making sure that we don't even acknowledge that the patient's in the hospital, so they don't know where to come and find that individual. Helping to liaison with our law enforcement agencies. Oftentimes your security department is going to have the best relationships with your local law enforcement partners. So whether it's your local police department, your local sheriff's department, your local DA, where you might be able to access some victim advocacy there, all of those things. And then just kind of ensuring that safety in the space. One of the things I'll echo with what Chris said is, it's not, from a security perspective, it's not our role to interview and investigate the potential crime. It's our role to provide safety in the space. And so we do have to be cautious about overwhelming people, especially people who have been traumatized. And that's going to be the case for any, assault victim that comes into our facilities, but in particular, with intimate partner violence and domestic violence and sexual assault, those cases, that trauma is extremely fresh and extremely real typically when you see it presented in an emergency department setting. So just trying to be as compassionate and provide as safe a space as possible for them to go through the process of meeting with the forensic nurse and meeting with law enforcement and receiving care for whatever injuries they have. The biggest and probably most dangerous aspect of our interactions is in the immediacy when we see a victim come in with the abuser. And that's oftentimes the case where we might see that victim come into the emergency department with injuries, and we have suspicions, whether it's from the nurse providing care or from the physician or whoever that might be, has suspicions of domestic violence, and we see that potential abuser is potentially in the room with us. And how do we potentially separate or allow for our care providers to gain access to the victim in privacy so that they can ascertain if there's opportunities there for us to intercede. So that can involve us separating that individual, moving them to a different location in the hospital, whatever that might be, but helping to provide there again that safe space. The other and probably more prevalent opportunity for us to intercede in domestic violence is when we have an employee of our facilities present with issues like that. How do we provide safety in the workplace for those individuals, and also work as a potential partner in helping navigate them through the criminal justice system to file charges as the victim, to work with them to help with temporary protective orders or whatever that might be in your given jurisdiction, and then partner with them to provide additional safety mechanisms in the workspace.
And that's absolutely true. So I myself, being in the 14-year relationship and working as a nurse in the hospital, I remember we started our screening questions around 2009, and we only screened for physical violence. I actually did not experience any physical violence until I was separating from my abuser. And so I remember thinking as I was working, well, what I'm experiencing must not be abuse, because I wasn't asking questions for that. We didn't talk about financial abuse or emotional abuse or sexual abuse. We didn't ask those screening questions in the hospital at all when we started asking those questions in 2009. So I think you bring up a really great point about being able to support employees as well. There's been articles, and incidences of domestic violence where it's the abuser came to the hospital to find the employee, and whether that was gun related or stabbing related. I mean, there's been incidences in hospitals of employees, experiencing domestic violence when the perpetrator comes there. So
you're absolutely right. I think the predominantly one of the most dangerous manifestations of active threats or active shooters in a healthcare setting is typically connected to domestic violence issues. And so I think that's one of the most serious threats that we see, not only in the protection of that individual employee, but in the protection of our organizations as a whole.
Yeah, absolutely. So Diana, just to ask you, and what can healthcare staff do if there isn't a forensic nurse available, like in their area? What can they do as far as documenting, gathering evidence? What does that look like?
Good question. Well, the bedside nurse certainly knows how to document. So if there's a wound there, a bruise there, an abrasion, she will go ahead and document that. That's part of her basic training, depending upon the area that she's going to work in. Again, they should all be trained in trauma-informed care, saying things that support the patient. What can I do for you? I'm sorry this happened to you. What would you like to do? And follow that line with that patient as to what they want to do. The reporting will become a question whether or not they choose to move forward. And if they do, typically that nurse will either notify law enforcement directly or have her radio room call the back line to law enforcement to send someone over. So keeping them safe, working with security if there's a threat at all there are very important. Explaining the treatment that's going to happen. So once the doctor comes in and a treatment plan is established, the nurse is going to have to go through and say, okay, for example, there's been a non-fatal strangulation that occurred with this domestic violence. So the nurse is going to explain that a CTA has been ordered by the doctor. We want to check your vein and your artery on your neck, make sure there's no leaks. And this isn't going to take long, but here's what's going to happen. So the treatment and then the discharge planning to include safety, whether or not there's an advocate there. Sometimes the nurse can call an advocate, but most of the time, if you're a larger emergency room, they'll have a social worker, and that social worker has a huge play in this, providing resources, whether or not she needs to go to a safe house, etc. So most nurses understand that. What they probably won't be able to do is take photographs, but they do have traumograms that they can draw on, and they can measure injuries and put it in their documentation. They can put their demeanor, was she crying, was she upset, in that documentation. So it should flow very smoothly.
Wonderful. That's such great knowledge and great information to share, because I think if I had ever, floated down to the ER to help out, I wouldn't have had all of that information. So thank you so much for sharing that. And just to piggyback on that a little bit too, we were unfortunately, she was not able to join us today, but we did have a caseworker who works for an insurance company that was going to join us. And so Diana, you mentioned getting a social worker involved. And I think what a lot of people don't know is a lot of times there's social workers and case managers that actually work for the insurance company as well. So that's another resource that people can look into. And even if you're an advocate, I know we have a lot of advocates that are here at different facilities. See if the person's insurance provides a social worker or a case manager as well. Usually it's probably going to more likely be like a behavioral health. So if the person or their kids need counseling or therapy or anything like that, the insurance company, a lot of the bigger insurance companies have them. I know for my daughter getting behavioral health, I actually got a call from the social worker that worked at my insurance company, and she did some legwork for me in finding somewhere that my daughter could go and receive counseling. So that is another resource for you guys too to kind of take note of.
So Sarah, just one more thing. I wanted just to go back to the question with Mike again about the repeated questions, the same question. Why are you asking me this again? I know that it's very frustrating, but if the nurse explains, I'm sorry I have to ask you these questions again, but I want to make sure when I create the report for you that we have everything down that you're going to say, then they just kind of go, okay. So that help. If you don't explain to them what you're doing and why, they won't understand, and that doesn't bode well in communication world. So anyway, thank you.
Yes, absolutely. It is repetitive, and I think setting the precedent and letting victims know like the process and what's going to happen, and if you can let them know ahead of time that some of the stuff may be repetitive and happen again, absolutely, it helps to ease that anxiety and understand what's going on. And like Chris said, it helps give them back some of that power and control, so they understand and they know what's going on. And what they can expect, and that helps you feel like you have a little bit more control over the situation that's just happened to you. Absolutely. Chris, so there's obviously law enforcement, they use what's called lethality assessments. I know I've read some articles recently that there's conversation on how that could be used in the healthcare, whether it should be used in healthcare. But would you just explain and talk a little bit about lethality assessments, what they are, what they're used for, and how one of those might be administered?
Yeah, and I'll tell you that there's probably not another way to impact domestic violence or deter domestic violence that I'm more passionate about than the lethality assessments. That's what I based my dissertation on. And I always tell people that domestic violence has been a problem for hundreds of years in our country. And we have a lot of things to deter, like drunk driving, drug use, things of that nature. We do more patrols. We set up red light cameras, speed cameras. We put all this extra work in deterring that behavior. But domestic violence, it's been a prolonged problem. Rarely are there any other implementations that we've had to try to deter that. And we know, and you hear this in the academy and throughout your career as a police officer, that domestic violence calls are one of the most dangerous and most frequent calls for service. So they happen a lot, and they're some of the most dangerous that you can respond to, yet we don't really do a whole lot to try to stop it. And the lethality assessment is actually a tool that we could implement to try to stop that behavior. And I could do a whole class on lethality assessments, but the short version is it's an 11 question checklist that officers read to victims of alleged intimate partner abuse. So it wouldn't be good for like brother, sister, mother, son, mother, daughter things. It's just specifically for intimate partners. And they use a weighted scoring system, and based on the responses from the victim, that victim is deemed high risk or low risk. If deemed high risk based on the scoring system, then the officers call a victim advocate immediately while they're on scene. And one of a national study showed that out of all the intimate partner homicides during the past year or 2 years, I can't remember the specific year, but only 4% of those victims actually contacted advocacy services. One could assume it's because they didn't know that those advocacy services existed. And I would be guilty as charged when I was a police officer because I didn't know all the services that victim advocates would offer. And it wasn't until I started doing research for the Stop Domestic Violence grant that I understood how impactful advocates can be for victims. The great thing about calling them on is that they are going to be more inclined to realize that they could be in a lethal situation just based on responses. So you'll have to look it up again. I could do a whole class, but there are two methods of scoring it, right? There's the first three questions. If they answer a yes to any of those questions, like has he or she ever threatened to kill you? Has he ever threatened to kill your children? Do you think he or she might kill you? If they answer yes to any of those, they automatically trigger what's called the protocol referral. And it sounds kind of Star Trek-y, like trigger the protocol referral, but it just means that you call an advocate while you're on scene. The weighted system is questions 4 through 11, and those questions are can he or she access a gun easily? Is he or she unemployed? Does he or she have children that he or she knows isn't his or hers? Right? So if they answer yes to 4 of those questions, questions 4 through 11, then you also trigger that protocol referral. And it's based on lots of research. And it's the brainchild of Dr. Jacqueline Campbell, and it was created by the Maryland Network Against Domestic Violence. But if there are advocates on here, many of you are probably familiar with the danger assessment. The lethality assessment was derived from the danger assessment, and it was created to give officers an effective tool that they could use expeditiously while on the scene of a domestic violence call. And one of the things that I tell people is when somebody screens in as high risk, when you're talking to a victim and he or she screens in as high risk, it's the officer's job to sell getting them connected to the victim. And it's one thing where they have to convey that, hey, many people in your situation that have answered similarly to you on this lethality assessment have died at the hands of the abuser. So you are in grave or high risk, or you're grave danger, or you're high risk for that lethal abuse, right? So I want to put you in touch with this advocate. And a lot of the pushback from officers is, well, I don't have 30 minutes to facilitate a phone call when I've got 2 calls holding or 3 calls holding in other zones, and my partners need backup and things like that. The job of the officer is to make that initial connection. The advocate can handle the rest. And it could be, hey, I've got so-and-so on the phone, and they talk for a few seconds, they exchange phone numbers, and the advocate calls the victim's phone number. Right? Or sometimes the advocate may come on scene, or the advocate may come on scene and take the victim to the shelter. Our mindset in the late 80s, early 90s, at least federally, was to get the victim as much help as possible to get them out of that situation to deter domestic violence. The second way, or what we kind of moved to, was offender accountability, which in my opinion, we fail miserably at across the country. Because you all know, if a victim doesn't show up to court to testify against the offender 90% of the time, and in Tennessee it's 99% of the time, they'll dismiss the case. And we all know or all probably know on here, the many reasons that victims don't show up for court. Right? So getting them in contact with an advocate who walks them through the legal processes, who encourages judicial participation, will really help get those convictions that we need to deter domestic violence altogether. Again, I could spend 8 hours talking about the lethality assessment. I've got a webinar through the Justice Clearinghouse about it on the 19th. If you want to check that, but I'll be quiet about it. But it's a useful tool. And in my opinion, if you've got victims coming to the hospitals or medical facilities without contacting law enforcement, I don't see any reason why nurses and doctors couldn't administer the same lethality assessment as long as it's covered under policy, right? Because it becomes a problem when you've got some people doing the assessment and then you've got some not doing the assessment. And it's more of a liability than it is a problem for that agency. So it's either all or none, but in my opinion, it should be all.
Well, yes, thank you, Chris. And there's a few questions in the chat, so I'll let you kind of read those too. You could probably answer those directly, but absolutely. And I think, one of my biggest, I was in the hospitals recently too, probably a couple of times actually over last year with COVID. And when the questions are asked, and it's all usually about physical, and I'll just kind of give a demonstration. I can't turn around. It's, are you being hit at home? Do you feel safe at home? And the nurse has their back to you, or whoever's asking the questions has their back to you, and they're not making eye contact with you. And so that's another another conversation that we could probably have for another day, but giving that empathy and being able to make that eye contact when you're asking those questions is another big aspect of it. And Mike, you and I have talked about, different tools that could be used in the hospital to screen for violent behavior, not just in domestic violence related, but also just violence overall. But could you talk about, is your hospital system using anything like that or working towards using something like that to assess for the risk of violence from either patients or visitors?
Sure. So we do use, or in the process of implementing a violence risk assessment in our electronic medical record. So it's something that is built into the process of kind of an automated delivery through either your inpatient, initial inpatient assessment or your emergency department triage process, so that we can evaluate the potential for violence. And give kind of that high, low, medium risk. What we don't have, and I think what healthcare is kind of missing in general, is something more attuned to domestic violence, which the lethality assessments that Chris is talking about, which I'm extremely supportive of as well, give us. They give us that kind of in tune, not specifically, one of the things we're looking for in healthcare is that patient going to be violent with our staff? Because one of the things we know from a healthcare experience is healthcare workers are 5 times more likely to be assaulted at work than any other worker. So when we're doing violence risk assessment, predominantly that's what we're looking for. What we don't have, and I think what a lot of organizations are missing, is that that specific look for the potential for domestic violence. So we do the traditional screening like you're talking about, where we're asking those questions that you hear in pretty much every healthcare facility. But I love the idea, and I'm a big promoter of the idea of having some of those very specific assessment tools that help us identify, especially if there's a suspicion of domestic violence, that help us identify the specific risks associated with that. And we do use a similar tool, not for our patients, but internally when employees present with a potential domestic violence issue. We do use tools like this in our internal processes to help us understand the potential risk to them as employees within our facility. So moving that towards our patient care is something that's a part of what we want to do, but definitely something that we do for the protection of employees.
Wonderful. So yeah, again, and I think that's part of the reason why we're having this discussion in the first place, is because we all recognize that there's more that we need to do, and we need to talk about that, share information, share resources, support each other in creating those policies and making that change so that victims can be supported in a much more concise and collaborative way.
I think to Chris's point, I think that's the challenge, right? You've got so many different pockets of individuals doing so many different things, but the ability to unify those processes in a more collaborative way is what really does the most to enable, empower, and support the victim.
Yeah, absolutely. So Diana, the AFN website, it does mention working with abusers and perpetrators too. So kind of along that same line of, we've made these assessments, we recognize there's an abuser or a perpetrator. And so perhaps that person has been brought into the hospital by law enforcement with injuries. And so would you just kind of discuss a little bit more like what really the role might be for a forensic nurse when they're working with abusers and perpetrators as well?
Sure, and that does happen. We do suspect exams. So it's an exam, a head-to-toe exam. We do ask some questions about a health history, but other than that, we don't go into any event history. That would be up to law enforcement to figure that out. We don't want to jeopardize any Miranda rights or anything. So our role would be just to collect the evidence, and that's swabbing, photographs, and documenting any injuries. Typically, law enforcement does bring the suspect in, and they do have to give consent. So we're not going to do this exam on anybody unless consent is given. Sometimes each state is different in how they choose to do that for probative evidence, or whether it's a court order or a subpoena, whatever it is. Just follow your local jurisdictional protocol. Once we collect, the forensic nurse collects the kit, turns the kit over to law enforcement, remembering the chain of evidence so that everything is correct and done in the proper way. We don't give an opinion about whether this exam is consistent with the history the victim said, not our role. So it's just that we uh, did the exam, collected the evidence per protocol. That's it. We don't know whether they're guilty or whether they're innocent. Okay, that's up to the courtroom and especially up to the investigation to determine. So we do want to stay within our role, and that's just making sure that we document any injury and collect evidence.
All right, wonderful. Thank you so much, Diana, for that information as well. So Chris, we're just talking about whether like if law enforcement had to bring in an abuser or perpetrator to the healthcare system, say they sustained injuries during an incident. And so what could healthcare expect, if a perpetrator or a suspected abuser or perpetrator were brought into the hospital with injuries that were needing treated and law enforcement was there with them?
Most always, you're going to have a law enforcement presence if they brought in an abuser and they need physical evidence from that abuser. And depending on the method they had to use to get that evidence, whether it's by consent or via search warrant, will likely indicate what kind of behavior that abuser is going to exhibit while he's there. So law enforcement and people on Mike's team, there would probably be a heavy presence there if they had to use a search warrant, and the abuser is very reluctant to give up any of that evidence. And you got to think, if there's been a sexual assault, there could be numerous areas or locations where the victim's DNA could be on the abuser, to include the clothes, the private areas. I mean, it could be anything, face, hair. I mean, you got to think they'll be looking for all kinds of evidence. And a lot of those abusers probably aren't going to be too happy about giving up any of that unless they've consented to all of it. Then it may be a more peaceful transfer. But the thing you have to keep in mind is if they've brought an abuser in there for evidence, then they should always have law enforcement presence, and probably in conjunction with the security professionals there to make sure things don't get out of hand. And depending on the cooperation with the victim, kind of like Mike said, you may have the victim present as well. There may have been an assault and the victim says he or she doesn't want to prosecute, and in Tennessee, we're a shall arrest state, so it doesn't matter at all if the victim wants to prosecute for domestic violence. If we can prove there's been an instance of abuse and we can prove the primary aggressor, then we make an arrest. We don't need consent to do that. So there's a lot of times where, I've personally arrested people and been attacked by the victim for arresting the guy that just, for lack of a better word, I guess, beat the hell out of their victim. And I was attacked by the victim while I was arresting the abuser. So that does happen, and it's just things to keep an eye out and keep an eye on. And hopefully there would never be an instance where law enforcement wouldn't be present when they're trying to get forensic evidence from an abuser.
So Sarah, I just have to concur with what Chris has to say. We never do those exams unless law enforcement is present in the room. And just thinking about safety, not having any scissors out, sharp things, those all need to be put away and secured. Usually they come in and they're cuffed, both hands and feet. So we do need them to take the cuffs off, because we do have to take a look at things. So just having law enforcement present and notifying your security what's going on, so they're aware of what's happening.
Thank you, Diana. And thank you, Chris, and to you, Mike. So now you've had this alleged abuser perpetrator come into the hospital system, and Diana and Chris have both echoed that your team needs to be informed. So what would your team do as far as once you're notified that a potential abuser perpetrator is in the hospital system?
Sure. So I think it's going to be different facility to facility how they work through issues like this when it comes to policy and procedure. One of the things we would be involved in from a security perspective is validating that there is a search warrant or something along those lines with the law enforcement presence to make sure that our staff aren't doing anything, because we have to be conscious of patient rights no matter who the patient is. And so making sure that we validate that documentation and assist with that. And then, our role is really to help facilitate safety for our staff who are participating in that process on whatever level. So if we have a nurse who's assisting in the collection of that evidence or whatever that looks like, making sure that we're helping with our law enforcement partners to ensure that they are doing that in a safe environment. We're not putting them at risk with that individual, depending upon the level of consent they may or may not be providing to the process. The other aspects of that, as Chris mentioned, and it's a very volatile situation when you have the victim there supporting the abuser. And so oftentimes what you'll see is policies where we separate and segregate so that we make sure that that's not happening with that individual in place. Try to connect them with one of our social workers or somebody like that in the family waiting room or wherever that might be, so they can have someone there to be supportive and to talk through that with them, and to provide potentially from a security perspective safety for them, but to ensure that they're separate from the process, and then to facilitate support for the law enforcement and making sure that we can get that collection done safely.
Awesome. Very cool. Well, I have just one last question for you guys, and then we'll open it to Q&A. I think like we've all said, we could go on for hours on this topic and probably have several more webinars, which we are planning a part 2 for next month. And so my last question for you guys is, after COVID and after everything going on and a lot of mental health awareness coming to light for law enforcement and for healthcare on kind of self-care, I'm wondering what each of you guys kind of do for self-care, how you handle the stress in your role, and any tips or suggestions you have for any of our attendees or anyone that watches this later, as far as kind of handling the stress that is specific to the role that you guys are in. So Diana, would you like to start?
Sure, thank you. This is really important that we take care of ourselves, because if we don't take care of ourselves, we won't be here tomorrow. And we need all of us on this mission. So things that I personally do is I love to exercise. So early in the morning is my 1 hour, all by myself, no phone calls, no one bugging me. It's my time. I often think of it like this. If you can think of 3 little things that you can give yourself that doesn't cost a lot, doesn't hurt anyone, and that you enjoy, then do it. Some people look for family and religion, so it's an individual thing. There's also another source out there by Dr. Nora Balden-Darren, and she does tapping. So in order to relax, she'll tap, tap, tap. I don't know if you can look that up or not, tapping, but that's one thing that I've seen some people do. So it's an individual, and it's up to you to make it happen.
Wonderful. I actually just downloaded a tapping app on my phone. So I'm a strong proponent of tapping and meditation as well. So Chris, would you like to let us know and tell us how you're taking care of yourself these days?
Well, I've been removed from, I guess, the actual exposure to these type cases for a while now, since my man for the better part of 7 years now. But I can tell you that exactly what Diana said, that I go to the gym, and even now, when I get stressed out, I spend my lunch at the gym, and even in the most stressful days and the days that I don't want to go or do anything, I feel like it makes me feel better. And as soon as I leave, I'm automatically glad that I went. And also, what she said, my faith kind of keeps me grounded and keeps me on the level, and it's kind of my guiding light. So when I have tough days and they seem to be affecting me more than most, then I lean on my faith very heavily.
Awesome. Thank you for sharing that. And last but not least, Mike, what do you got for us?
I drink copious amounts of caffeine and terrible food. It's my primary coping mechanism. I like it. Chris, I see what you got there. Yeah, I like to tell people that coffee is my primary source of hydration. But no, I think, this is a challenge. I think especially in the healthcare arena over the last year more than anything else, because we've been, so short-staffed and so slammed with, COVID and all the various things associated with COVID. And like I mentioned earlier, workplace violence in healthcare is reaching new heights, which includes what we're seeing with our domestic violence statistics as well in the post-COVID world, as people are starting to reemerge. And it is an ugly reality that you have to deal with on a regular basis. I tell my guys on a regular basis, we have an opportunity to enter people's lives at their worst possible moment and provide help and safety and support, which is a truly awesome responsibility, but it takes a toll. And so, yeah, the things that Chris and Diana both mentioned, exercise on a regular basis, quiet time on a regular basis, unplugging on a regular basis. Like Chris, my faith is a big component of how I deal with the stress of everyday life personally. But being in a leadership role, it's trying to figure out how do we help our whole team do that, because I've been removed from the front line for quite a while, so I don't have to endure as much as some of our officers do on a regular basis. But making sure that we provide space for that and connecting them with resources and employee assistance programs and counseling opportunities and critical incident stress management when we deal with particularly hard cases. So those type things are all tools you have to keep in the tool belt on a regular basis, because it is a difficult place to live when you're dealing with or experiencing other people's trauma or witnessing other people's trauma every day.
Yeah, absolutely. So I probably did not really start practicing self-care until much later in my career. I remember nights where I'd wake up and I had a little one, so I was breastfeeding in the middle of the night, and I would remember something that I didn't tell the night nurse on report or something, and I was calling. And so you're just kind of always taking care of, everybody else except for yourself. And so definitely these past few years has been more of a focus on self-care. And I think overall in an industry, whether it's law enforcement, healthcare, leadership, self-care and taking care of yourself has definitely become a focus, even more so after COVID. So thank you all for sharing that. And thank you for being here today. I think Sherry, are you coming on? Sherry's coming on.
Well, lots of discussion going on in the chat. This has been more active chats, which is fantastic. So, okay, I see Tiffany has to jump off. We have a few questions here. Police and hospitals tend to identify physical abuse. How often are police forces using assessments for non-physical forms of DV? Is screening for non-physical or coercive control? What tools do you use? I mean, you guys talked about the lethality, but are there other tools as well?
The danger assessment is what most advocates are using, Sherry, and that is a kind of an extended version of the lethality assessment. And the reason it's not very feasible for law enforcement officers is it's very time consuming. And it also works on a weighted question system, but it also asks the victim through a full calendar year and indicate instances of abuse. Now, obviously not specific dates and times, but in the month of August, can you remember that you were abused, and if so, how many and by what means? And so you can imagine it takes a victim a long time to try and remember all of those instances of abuse, to where officers likely have several calls holding. But the danger assessment is a really good tool. And for me, the lethality assessment is kind of all encompassing. So it isn't just for physical abuse. It kind of takes into consideration all the other things. The first three questions are more specific to physical abuse, but questions 4 through 11 in that weighted scoring system aren't necessarily all about physical abuse. Like, it asks if the person is unemployed. Does he or she know that he has children that isn't yours? Does he leave threatening text messages or follow you? Or, none of those have anything to do with physical abuse, yet there are implications there that could lead to that. So if they answer 4 of those questions yes, then we know we've got a high risk situation.
Yeah.
And unfortunately, and I apologize ahead of time, but I've got to run to another class.
Okay.
So I just want to say it's been a pleasure meeting all of you on here, the presenters as well as the attendees. And Sarah Marie, if you want to throw out my info, I'm happy to answer any questions after the fact.
Yes, I do. I have a slide. Oh, go ahead. Yeah. Sorry, Sherry.
All right. Thank you.
Yeah.
See you all.
Do you want to go ahead and share that slide, Sarah Marie, so that everybody can get that information?
Yes. Yeah, I can do that right now, actually.
Yeah, we can do that now.
While she's doing that, this is Diana for the medical piece. Most hospitals have computer charting. So those questions are embedded in that initial screen. And don't forget, we're looking for human trafficking as well. So not only for DV, strangulation, human trafficking, sexual assault, all of those questions are embedded, and it's up to each institution to determine which screening questions they're going to use. And most of them base that on the current research so that it's evidence-based practice.
Excellent. All right. Well, take a screenshot of this, and don't worry, we are recording the session, so this information will be made available in the recording. Sarah Marie, Diana, Mike, and Chris, who already left, on behalf of the audience and Victims Voice, we'd like to thank you for today's Lunch and Learn. For those of you who have further questions about material covered today, or whose questions were more specific or were not addressed in the Q&A portion, please feel free to contact me, and I'll make sure your question gets to the appropriate person for follow-up, or you can reach out to them directly as shown on the screen. Our upcoming Lunch and Learn programs will be centered around the intersection between healthcare and domestic violence, continued, but from a victim-centered perspective. The next program will also be sponsored by the Academy of Forensic Nursing. And as shown here, we are doing a fundraiser to help raise activation cards for the Victims Voice app in a virtual concert. So we're going to have bands from all over the world, and we're going to have a concert, and that's the date. So stay tuned. More information to come. And if you'd like to be notified about our upcoming events, you may subscribe to our event-only mailing list on our website at the URL shown here. And you may also subscribe to us on